Wow.
All right. Hello, everybody. This is Tom Randall. Want to thank you for jumping on today and spending some time with us on this webinar. It's my pleasure today to offer this. It's a WOW, an acronym. You'll hear a lot about acronyms today, but this Words of Wisdom webinar series. And basically, we call this secret gaps. And some of this information obviously is going to be out there that you guys have heard about. But at the end of the day, I just wanted to make sure we covered a couple things that I thought were pretty interesting when it came to this extended care market. So we're going to have some fun today, do some housekeeping first, let you know that you don't have to take copious notes because you will get these slides, hopefully access to a recording if that all works out. And then we also have our website that you can go to in the upper right up there, goldencareagent.com, and our phone number and all the tools that we have that I'm not going to spend time on today. But I tell you what, I'm blessed to have one of the best marketing staffs out there, if not the best in the industry, to help you guys be successful in the field. So that being said, we'll get rolling here. If I can get my computer to play nice. Won't have you looking at my ugly mug too long, but I do want to let you know that I've got a lot of experience with Golden Care. I've just had a ball with this job, helping create different products, working with my team to do our best to help people out in the field. And we're looking at 50 years this year. 74 was our inception year, well before my time, obviously, but Lenny Anderson did a great job building up Golden Care, and you'll be seeing more things coming through our social media, etc., this year as we celebrate 50 years of trying to help you. And this little dude, if he's working on your screen, it's the closest I could get to drinking out of a fire hose, because if you've trained with me before, you know that I go through a lot of stuff, and I go through a lot of stuff fast, and I apologize, but so much of it hits this topic that I do want to let you know that, remember, you'll have the slides, and I go through some of this early stuff quick because I want to get into some of the more exciting stuff and some of the things we want to hit on this webinar. So especially these early slides, I apologize, I'm going to zoom through them pretty quick. And some of you have seen these before if you've been on other webinars of mine. I'm really passionate about what I do, because this slide to me is one of the most important ones out there. The stats don't lie. 70% of the folks, especially when you're working with short-term care and home health care with the looser triggers than what we had with long-term care, people use these policies. And unfortunately, we still have a huge percentage, 90% of adults have never really had a really serious conversation about what it is to look closer at long-term or extended care planning. So we have our COVID stat down there, of course, that just to me shocked me at the time, when people are out there literally in a nationwide survey saying, hey, I'd rather die than go to a nursing home. So we always stress to you folks that we're not really selling nursing home insurance. It's part of what we do, but the key is we're trying to get people to stay out of the nursing home. Okay. And when I get into this slide, for example, this is one, there's a lot of stats, and this is for agents. Remember, I'm training you agents, trying to get under your skin a little bit to get you to go out there and work hard in the trenches. So these stats are obviously, you're going to see that I'm coming up with a webinar in the near future here about how to present the sale and how to go through from A to Z in the sale. We don't talk as many stats with seniors, but I wanted to make sure you guys know, if you're selling these type of products, or if you're on the fence about selling them, we need you, because we have a crisis in America. Those baby boomers, 2030, they're going to be hitting claim age, quote unquote, and we need to have some answers for people. So we have a lot of gray hair in America. And you look at that stat, there are 70 million seniors by 2030. When you look at that, lucky we're not selling nursing home insurance, right? Because we always talk about the fact, if you started today and built two nursing homes every single day with 196 beds, you wouldn't even have half enough nursing homes if a lot of those seniors had to go to nursing homes. That's only 1 million extra beds. So if you look at it, there's only 3 nursing homes open in 2023, back when this was end of last year. And there were closures of, almost 580 of them in 2020 up till 2023. So needless to say, if you read the news or if you're all out there, you know the nursing homes aren't popping up all over the place. We know there's some assisted livings, but even those aren't touching what would be needed if we didn't have good home health care protection for folks. So the costly aging, again, drinking out of that good old fire hose, this is one that I just stress to people. We all know it, right? We all know the studies, the numbers are a little bit different, but we know the Government Accountability Office doesn't hide anymore that there's trillions and trillions of dollars of unfunded liability exposure out there for America. Medicare, 821 billion right now, at 23 is close guess we can get. 65 million people out there, those 58 million seniors are going to be in that mix. And Medicaid, you know, is right behind it, or ahead of it actually right now, 853 billion. Tough to pin down the exact Medicaid numbers because they have the chip, the child health, et cetera, in there. But needless to say, those budgets are tight, and especially Medicaid budgets. So we're going to see some issues, and we're going to see people's heads turning, because years ago, I've been doing this a long time, as some of you on this call have. I recognize some of those names. Remember 20 years ago, we'd go to webinars or seminars back then, because nobody knew what a webinar was. But we'd go to seminars and they talk about, boy, the year 2030, we're in trouble. This whole economy is going to fall apart. And the reality is now 2030 is just right around the corner. So the good news is we're going to have a lot of heads turning. The bad news is it's going to be a crisis in America as people start struggling out there, because we know Americans are concerned, right? We know they're out there saying, hey, I don't know for sure how to handle this. And we know 3 out of 5 personal bankruptcies are due to medical expenses. And if you really dig into this stat, it's not hundreds of thousands of dollars of medical expenses. It's usually people who already have medical insurance and they're out there getting hit with just a, you know, how many people do you know who couldn't handle a $50,000 surprise debt? So we know it's a big issue. Unpaid caregivers, again, this is stuff maybe you've seen if you were on my year-end webinar, but I just want to remind you, as we talk about some of these secret gaps of coverage, these are all part of that picture, aren't they? Family caregivers, people wait too long, and there's family caregivers literally killing themselves trying to take care of mom and dad. And we know that this is something that's important for folks like us on this call to go out and help people prepare so they're not that big a burden on their family, right? And when you get to the paid caregivers, we all know this news story, right? This is from January of this year. We're seeing a major fallout. COVID did not help the situation. Those people are out there underpaid, and they're out there trying to figure out a way to keep enough people helping, both in the facilities and at home. So we know it's important to have some flexibility in some of these coverages, and that's why we have that cash benefit in our Omniflex plan, because we want to make sure we can keep people at home as long as possible if we can, and people have to plan ahead so that they're going to get better care, because in those facilities you're going to have slim pickings if you're going to start going on the public bankroll as this gets worse and worse. So again, I'll get off my soapbox there, but I just wanted to make sure I hit some of those topics as an introduction. And as we dive into this, you know, you all know the shifting market story, right? We, Golden Care, would prided ourselves in being a leader in the long-term care market. We've written over $1 billion worth of long-term care with our sister company, AIM, out in Yakima, and we knew how important long-term care is, and we still do. We're not throwing in our cases on long-term care, but at the end of the day, we know it's a tougher market. And you guys on this call know, and you've probably seen the same slide several times through Golden Care here, is that the old days we could go out and help more people, and then all of a sudden we got to the point where, whether it's traditional long-term care or hybrids, it's not that easy to go out and get through the underwriting hoops, especially when you get the gray hair involved and you get into the 60, 65 plus market. So we know that there's issues there. And what we want to do, and what Golden Care is making a concerted shift towards, is saying, let's start being smart. Let's change the paradigm. Let's go in and start looking at all of these great short-term care and these great home health care only plans. And we even have Chubb in there, which is a really fantastic little life plan that's a guaranteed issue for a nice amount of coverage. So we have some good things out there. True Freedom, can't speak enough about it. It's not even an insurance policy, it's a prepaid health plan. But I'll tell you what, it's available in all 50 states, because the one weakness with all these plans is that they're selective. Some states just won't look at it yet. We think that'll change slowly but surely, but we know True Freedom's great because it has access to all the other states as well. Okay. Again, I just like this slide. Lynn did a great job in our team putting it together, so I included it in a lot of them, because right now this is where we're at. We've now looked at these new short-term care plans, and they've been around for a long time, but the newest plans out there are so strong and so flexible that it gets to the point where, especially, I'm not going to kid you, Omniflex, our team worked really hard working with Manhattan Life on Omniflex. And if you're not familiar with it, get familiar, because we built that plan around the concept of saying the biggest ability of these plans is the availability, and part of that is underwriting. So you're going to see the Omniflex plan has some really nice options involved and makes it very competitive at claim time. but also it's available without throwing that underwriting net, really constricted. So it's something that you're going to see tons easier to get it in place, as are the other home health care and short-term care plans, but Omniflex especially, we're really proud to say that that's going to be there. So that leads me into what we're going to talk a little bit about today. And again, don't worry, I'm not going to teach you how to sell med supps and I get into that too deep, but I do want to make sure we understand that there's one of the biggest secret gaps out there right in front of our face. And some agents know a little bit about it. And I put this together today to make sure you knew you'll have these slides so you can kind of get an idea of what we're doing. And again, the slides I'm showing you today aren't going to be slides you're going to sit and throw out in front of a lot of your clients, but I want you to understand that one more reason why you want these arrows in your quiver at the time that you're going out there to present to people. So quick refresher in Medicare, Part A, remember, is hospital insurance. That pays for inpatient hospital stays, $1,632 deductible per inpatient hospitalization. They got like a 60-day benefit period, right? Then if you need 61 through 90, you can pay a 408 copay, 1/4 of what the annual deductible is. And then we have 60 lifetime reserve days that in 2024 is half of what that deductible is. So 816 for those one-time 60 lifetime reserve days. And again, I'm not going to go in and answer every question on Medicare today. I just wanted you to be aware of this broad bird's eye view. After the inpatient hospital stay, the key is inpatient, as you're going to hear in the next few minutes. Medicare Part A covers the first 20 days at 100%, right? This is all stuff most of us on this call easily know. And in 2024, the copay is $204 for days 21 through 100. So the trustee report, the good news, as always, we know these funds are underfunded, like we talked about. Part A trust fund, they say it's going to be depleted for the last 10 years. They say in about 6 years. So no difference here. They are saying now 2028, it'll be depleted and we'll be $247 billion in the red by 2031. So we know Medicare's in trouble, and that's why there's been so many changes in Medicare, as we'll talk about in a few minutes as well. Okay, Part B, Medicare, remember, medical insurance, right? This is for outpatient services, all the things you'd expect, the doctors, specialists, mental health supplies, preventative benefits, labs, outpatient hospital treatment, and durable medical equipment. And with that one, in 2024, there was a standard monthly premium that most people pay, $174. Of course, there's one of our first acronyms here, the IRMA, the income related monthly adjustment amount, meaning if you make more than $103,000 as an individual, as the AGI, or 206 as joint, you pay a higher monthly premium for Part B. Okay, simple stuff. And again, these slides will be there for you later on. The 2024 deductible is $240 annually, and then you pay a 20% no max coinsurance, which is important when you start looking at what we're going to talk about a little bit today as well. While this is major league underfunded, like the whole Medicare system, the Part B, the premiums, they have the ability to raise those premiums obviously each year, so that helps offset it to some extent. But if you look at Obamacare, how many remember 2010, the Obamacare Affordable Care Act? Remember, there was a 10-year Medicare reduction of $716 billion with that act. And as you can see here, a very large portion of that is on Part A, right? Part A, you got the hospital, which we're going to talk about a lot, $260 billion cut, home health care, skilled nursing, hospice care, et cetera. Part A got beat up pretty bad with those cuts. And that really led into what Medicare did even before that, but especially since that, is they cracked down on hospital readmissions. This is something that I want to make sure you're aware of. Number one in 5 Medicare patients, because they're older, because they come in with some tougher conditions sometimes, when they go into the hospital, it's pretty astounding to realize that 1 in 5 Medicare patients are readmitted within 30 days. And Medicare knows that, but there's going to be things like surgical site infections, et cetera. But in 2012, the government found that a lot of these could be avoided. So what they did is they started to look at it and say, Medicare costs double due to just one readmission. This is a 3 years old stat already, and it's $15,000 they projected, and $33,000 for patients who had been readmitted once in that 30 days. So they knew it's a big cost for Medicare if people get reinstated, and the preventable readmissions that study found by the government said it was about $17 billion that Medicare spends on things that are preventable, not just the ones you'd expect that would have to come in. So this could be a half-hour subject. I studied it quite a bit, actually. And really what you found is there's a lot of jargon going back and forth, and it's an imperfect science. But at the end of the day, the government decided, you know what, we're going to start penalizing hospitals if they have readmissions that probably shouldn't have been readmitted, if they could have handled it on the front end. And you know what? It's a major problem out there for Medicare, a lot of money. So when you look at $17 billion, they didn't correct it as well as they thought they would. But you can see what basically what they do is a 3% penalty on Medicare reimbursements if you find that your hospital was out there having readmission issues. And you can see here, 93% of the hospitals that were subject to the HRRP, another acronym, the Hospital Readmissions Reductions Program, 93% of them have had some penalties at least, not all the maximum penalty, but some penalties. So this is a big hit on hospital. They shift the costs over on this to over to a lot of the insurance and private pay, but it is an issue. So I'm going to go off and totally we're going to have fun drinking out of a fire hose today. I'm going to try to start this video and see if it works. I have it linked right in here, and we'll see if that works out for us. This is a short one. Now we got to think through. I knew on a webinar we have a little D here, so I'm hoping this is going to play nice. Bear with me.
Patients are being readmitted to hospitals. Officials say it's costing you billions of dollars a year. Now, several Indiana hospitals are looking at fines because of it. 66 Indiana hospitals will be docked $12 million total next year. That's in Medicare payments. Federal officials say too many patients came back for care within a month of being discharged. Only 17 hospitals in the state will not be penalized. Officials say readmissions are often unnecessary. It's usually because of treatment that should have been prescribed during the first visit.
All right, so again, oops, there we go. If somebody on my team let me know if you guys couldn't hear that or whatever, but hopefully that went through as smoothly as it looked like it did on my computer. So again, this is a big deal, and it was something that, you know, got them back some money. It looked like 521 was the last stat I could find for fiscal year 2022 that it saved Medicare. So they looked at it and thought, well, we need bigger Part A Medicare savings to hit our goals. So this is where they jumped in, and there was a huge business in Medicare hospital audits. And one thing I learned when I was researching this is that the government, especially Medicare, apparently loves their acronyms. So over here on the right-hand side, basically I'll walk you through it. It's first the MACs, the Medicare Administration Coordinators, along with the MRACs, the Medicare Recovery Audit Coordinators, enforced oversight for Medicare, and then the TMR, the 2 midnight rule hit after 2013, and then the OPS, the Outpatient Prospective Payment System, says that the BFCC, the Beneficiary and Family Central Care Organization, a QIO, Quality Improvement Organization, conducts the IMR, which is the initial medical reviews, starting in 2016. And, you know, luckily after all that, the hospitals have the 392-page MCPM, which is the Medicare Claims Processing Manual to help them out. So in a nutshell, you're right. You know what? Now you see why we named this webinar Secret Gaps, because most of you on this call wouldn't even want to subject themselves to reading through, because I'm not kidding you. When I read through a bunch of things for research on this, they tell you what an MAC is once, they tell you what a BFCC is once, then you read a 32-page document and it brings it up and just calls them BFCCs and IMRs, and you end up just being, you want to tear your hair out. So I saved you that by just telling you a little bit and trying to truncate it down. So let's talk a little bit about Medicare recovery auditors, okay? And again, drinking out of fire hose a little bit, but basically these MRACs are third-party contractors hired by Medicare, and their job is to determine the legitimacy of those patients' hospital admissions. So now we're talking about admissions, and then there's that readmission penalty we talked about, but this is just in general. They're talking about, hey, you know what, if we get a heads up from one of the Medicare administrative contractors who kind of parcel through all these different Medicare claims, and there's a lot of them every single year, right? If the hospital or doctor makes a wrong decision about admitting a patient, that MRAC will contact Medicare and they'll validate it and say, you know what, this looks like somebody that shouldn't have been admitted. It should be something that they could have got done on an outpatient observation basis. So guess what? Instead of that 3% penalty, Medicare can validate it and come back to that hospital and literally sometimes years later say, we're taking 100% of that Medicare reimbursement back because this person shouldn't have been put as an inpatient. Well, guess what? The MRAC, of course, receives a nice compensation for each one that they find invalid, so it behooves them to go out doing it, right? And the hospitals, remember, they can get paid if they have it as an observation through Part B Medicare, not quite as much, but they still get paid, and they're really afraid of this whole thing. So this sounded like a great idea for Medicare to say, hey, we're going to watch your back and make sure that we validate your inpatient statuses so that you're not taking advantage of Medicare and making it too easy on everybody. So you can see at the bottom, whenever the government gets involved, you can see there's going to be problems, right? The hospitals don't like getting stiffed. So now we get into that world of observation versus inpatient. And some of you know about this, and some of you, I give big credit at the ILTCI conference, Jamie Sarno, who helped develop that short-term care plan, gave a webinar on this. It was kind of labeled as Aetna short-term care, but then he went in and talked about a lot about this observation. And I remember that I'd known about it, but I thought, boy, that's pretty interesting. Maybe I should do a webinar on this to talk to our agents about it, because it actually is a pretty significant issue out there and it's ongoing. It's a moving target right now. But anyway, at the end of the day, remember the Medicare Part B medical coverage, the hospitals can use observation status and still get paid because part of Part B pays for outpatient things through Medicare, but they can avoid that inpatient audit that we just talked about. So what happened is this observation status really dramatically increased right out of the gates. From 2007 to 2009, the ratio of observation stays to inpatient admissions increased 34%. From 2002 to 2012, the number of observation claims submitted increased by 88%. And in 2013, the CMS adopted that TMR, the 2 midnight rule, and that they thought was going to help doctors with their admitting decisions. They were hoping the observation claims, those stays would go down because of the 2 midnight rule. Well, in a nutshell, the 2 midnight rule was vague, right, as well, right? So it basically says inpatient admission and payment are appropriate when the treating physician expects the patient to require a stay that crosses 2 midnights and admits the patient based on that expectation. So at the end of the day, it didn't help, right? The fear of no reimbursement, that 100% penalty, and the penalties for readmission was too big. So what we saw there was actually an increase right after the 2 midnight rule came out. They saw a considerable increase again in that ratio and the number of observation stays, because the doctors were getting lectured from their administrators saying, be careful, don't admit people unless you see it. Some of us on this call, I guarantee you, have been victims of this, right? My mom, for example, my brother John and I talked about it several times when she was in the latter years of her life. They would come in and start talking to her about observation versus inpatient. So it is an issue out there, because potentially what it means is more out of pocket. And there's that 3 midnight rule for skilled nursing facilities, right? They basically say, hey, if you're in for to get three-day inpatient requirement, you need to have an inpatient status for those 3 days for skilled nursing to follow up. And that's a big deal with a lot of seniors, especially for rehab. So here's a little cutout from the skilled nursing facility 3-day rule billing that basically says what I just said. So you know that got to be an issue. And you know what? Do a couple Google searches out there and you're going to see the implications of it. Patients can get hit with huge unexpected bills. They happen all the time. And even today, as things are really starting, the government's aware of this and people are aware, and there's groups out fighting to say, we got to be more lenient. And Medicare Advantages do a better job in some situations, but it is still an issue that's worth you as an agent at least knowing that it potentially be out there. So I'm going to show another video here. And again, this one's, it's a little bit older video, but it did a good job of embracing both sides of it. So I decided to use this one as well. So I'm going to do this again and hopefully it'll be smooth. Might get a free ad for something on you, sure. Golden Hair in no way embraces this 5 seconds that you're going to hear here.
And I want you to.
All right.
79-year-old MJ Riku is doing physical therapy after a bad spill in September. She spent 3 days in a hospital. She got the same care as an inpatient, but she wasn't classified as one. Instead, her chart said she was only under observation.
I mean, it's illogical. I had a broken leg. It just didn't make sense at all. What were they going to observe?
And here's what she didn't understand at first. That label, under observation, technically made her an outpatient. And that means Medicare won't pay for her rehabilitation in a nursing facility, which costs $28,000.
The whole thing is so outrageous, and it's not right.
It's a huge problem. There are over 1 million, almost 2 million people every year who are stuck in this observation status, Alice in Wonderland world.
I'm not going to, this just goes into some numbers of observation. I'm going to go up to 105, just so you don't have to listen to the full 2.5 minutes.
Coverage. To the patient, to our viewers, frankly, it seems like the hospital shares at least part of the blame for this.
Sure, they're in the hospital. They're going to think all of this is a hospital decision. Much of this is out of our hands.
Rich Undenstock, who represents most of the hospitals in this country, says they're being squeezed by Medicare. Inpatients cost more, so Medicare aggressively audits the classifications given to patients.
If you make the wrong decision, if you admit a patient to inpatient status, and then they determine after the fact, sometimes years later, with additional information the physician didn't have, they will take that payment back. Unfortunately, the patient does get in the middle of this.
All right, finally, I'll just finish with a little bit more on the personal touch. 204. See, I'm trying to save you guys time.
MJ finds the whole thing unfair. She and her husband, who's had Parkinson's for 20 years, just moved in with their son in Dallas to save money.
I've worked my whole life, and I'm just appalled.
Now any money they can save will go to her rehab.
So far, legislative proposals to fix this problem have gone nowhere. Advocates say Medicare patients who end up in a hospital should make sure they've been admitted as inpatients and aren't just under observation. And if all else fails, ask to challenge the decision with Medicare. Brian?
All right, you know, and again, I'm just showing you guys that video. It wouldn't be used as a scare tactic with your clients or anything, but I wanted you to know it is out there and it does happen. Even with the changes right now that they're trying to solve this, and we'll talk about just real briefly in a couple minutes. These are something. Imagine if you had a loved one in this type of situation. You know, literally that John and I have been in insurance, and the rest of our family were all in the medical background. So when they came out and told us about this observation thing, we knew enough to kind of say, hey, you know, what's going on here? So part of the move for that, many of you heard that the Notice Act went to the moon, right? The Notice Act of August 2015 tried to help with this moon. It's called a Medicare Outpatient Observation Notice. Finally an acronym that made sense, right? So this was at that time required that no later than March 8th of 2017, hospitals had to start using this moon notice. After they've been under observation for 24 hours, then they need to give the moon within 36 hours from the time they came into the hospital. And basically what it does is it informs patients that they're receiving outpatient observation and they're not inpatient. And you know, this was actually a nice thought, and it did help for people to get a heads up, because if you read the form, it gives you a couple red flags, as you'll see. But at the end of the day, most people, you know, they're in a hospital. Most people aren't in the medical field. They're looking at it like, whatever, here's something I'm supposed to sign from the doctor here. And they sign it without knowing really what they're signing. So it is obviously something you'll see that they sign it, and you want to make sure that people aren't signing their life away, because they do have limited rights to appeal it or to actually challenge their status. But before they sign that form, they can have a pretty detailed talk to people. So again, it starts out on the top just saying you're getting outpatient and you're not an inpatient because, and then they write in the reasons there. But then down below that, it does talk about a lot of different things that I tell my agents, especially now, as a courtesy, if you're out talking to any seniors, just tell them about the moon. It's easy to remember and say, you know, if you ever do go to a hospital, make sure you remember the word moon, because there's this form that they're going to have you sign if you're under observation status. And you know what? It can affect a lot of things. It might affect how much your client's paying in the hospital. So the hospital side itself, there's a section on there talking about Part B, and you might have more out of pocket. It can majorly affect what happens to you after. If you have to go into a skilled nursing facility, for example, there's that 3-day rule. So it does talk about things like that. So tell your clients when you get in there, you know, medications could be affected. Obviously, Medicare Advantage plans handle things differently. So look at their Medicare Advantage plan. But again, you don't have to get into the weeds with them, but what a nice courtesy for people to say, remember, if you do go to a hospital for any reason, make sure you pay attention if they have you sign any forms once you're there. Tell your family members, be on the lookout, make sure they read. It's a simple 2-page form, but it does make a significant difference, as you saw in that video, potentially the worst case scenario, but it can be a huge, huge difference, especially if they need to have care afterwards in a skilled nursing facility, which is really common. Like I said, if somebody's in their walker, falls, hurts their hip, breaks their arm, all these different things that younger people heal from quicker, but older people are like, boy, we better send you into a skilled nurse facility for a while and go out there and help you out with that. So needless to say, for what we're doing today on the sales side of it, you're helping seniors by getting these short-term care plans in place and these home health care plans. But what a great lead in then, as you do your courtesy reminder of the moon, that's where you bring up saying, you know, one of the things we're telling folks is that most people have never had a conversation about extended care. And this is just one more reason that these policies can be a lifesaver for you. So again, I do want to, for full disclosure, the topic is still a moving target. But remember, Medicare funds are tight. There's the Improving Access to Medicare Coverage Act of 2021 that proposes solving these 3-day issues, saying whether you're there for observation or inpatient, let's wash the board and say no matter what, you can go to a nursing home. I joke here saying probably won't work because there's no acronym for that. They didn't use an acronym, so I thought that's probably a red flag. Obviously the JK, I'm just kidding on that, but 2021, the Outpatient Prospective Payment System, this one has an acronym, unfortunately, the APS, and this plan is to actually hurt the seniors again, I think, because they're trying to phase out. They had a list of these 1,700 different procedures that a hospital does. It said, we'll only do these procedures if you're on an inpatient basis. So what happens if they get rid of that and phase those out, then it'll be more observation statuses for those 1,700 procedures, which again could compromise that skilled nursing facility access. So we know, because Medicare funds are tight, that there's lots of problems out there with Medicare and it's underfunded. And I don't think anybody on this call would say, oh, I'm betting they're going to loosen the purse strings up and just give away more and more money. We know that there's going to be problems with funding this, and we know that there's a big portion of the population out there, who are going to say, we don't want to loosen it up any more than it is. We know the seniors are important, but we better start having people plan ahead and get their own coverage. So basically that last one is just a word of warning saying, you know what, I don't trust anything to do with Social Security or the government beyond the extent that we know it'll be there, but as far as to what extent, we see a lot of problems there. So always, that's why I'm passionate about it. I want people to plan ahead with long-term care or a hybrid plan, or if they have health issues, plan ahead with a short-term or home health care only plan. Because the one thing that I always pound with you guys, and you've seen this slide before, if you've been on with me, you know that these plans are not your old long-term care plans. With having the triggers to these short-term care plans or the home health care only plans that don't require that 90-day requirement for care, that's a huge difference. Now, all the things we just talked about, that Medicare is in the picture too, those things are there for you, saying you may not need 90 days worth of recovery. And a lot of people still have that, oh, I don't know if I'll have a big dramatic claim, so I don't know if I need this coverage. Remember, we talk a lot about how powerful these plans are, and they cover things like the knee replacements, broken bones, cardiac problems, bypass surgery, hip replacements, motor vehicle accidents that you recover from. At any age, these plans are going to come into effect. That's why that 70% number is so accurate with this, or 90% for married couples. Most people can see themselves needing a smaller claim. I call that a premium justifier, right? Now, when we sell an Omniflex plan, for example, or one of the other big quality short-term care plans out there, you know, you literally can have your cake and eat it too. Remember that old adage? You can go out there and say, get this plan in place now. We can get you there because the underwriting is very lenient compared to long-term care. And when we get this plan in place, you know what? It's there for both sides. You could have your protection if, God forbid, something goes south on you with what we just talked about with observation. But more importantly, even if it doesn't go south, these are indemnity benefits. They don't care what other insurance you have in place or Medicare or anything else. If you go on claim and you get care, it's going to cover you. So this one, you can have those little smaller claims. And at what, you know what, at $200, $300 a day, those add up fast where you're getting a lot of premium dollars back in a short time. So you have that indemnity benefit coming in, even if Medicare does pay or your other insurance pays, it's still coming in the door to help you out. Then after 180 days of being healthy, remember these restore, the benefits restore. So now you can have your cake and eat it too. Your really powerful part of your plan where you can have a year worth of home health care and a year worth of facility if it works out that way. Those can be $500,000 worth of extra protection waiting for you for that more catastrophic claim while it's still paid for your shorter claims earlier on. So when I say have your cake and eat it too, there's a reason that cake's smiling. And again, we didn't even have to get into the Medicaid, so don't worry, I'm not going to pound you on Medicaid today. But everybody on this phone call knows Medicaid in general, it's too easy to get. Steve Moses will tell you every day of the week. It's too easy to get. We're having it as more of an entitlement program, but even so, there's weaknesses with that, right? This one shows about the home. They'll put a lien on those houses still. Guess what's going to happen as Medicaid gets tougher and tougher and more in debt? They're going to come out and they're going to say, we got to start doing a better job of asset recovery. So we know that Medicaid has a lot of problems. People don't realize that you can get shifted out of Medicaid beds. Remember I talked about nursing homes are losing money because Medicaid doesn't pay enough. So they're looking for private pay, and they have a limited number of Medicaid beds that they'll move people around, as you've heard stories in the news. So I'm not going to get on that too deep. All I want to let you know is we have plans available to help you for all of these different issues. And again, we talked about a lot of things today, and that Medicare observation isn't the primary sales maker, but it is one more feather in your hat to tell people, why do you want to worry about stuff like that? Let's get something in place so you don't have to worry about some of the hidden surprises out there that our government does a good job of throwing at us once in a while. Okay, so again, here's a map. All I'm showing you this for is to remind me to send you over to our site. We've got availability in most states. Some of these states, I'm living right in the middle of one, are a little bit scary when it comes to short-term care, but we're actively working for sure in Florida and Minnesota trying to say, why don't you guys get smart and give your people in your state a better availability for some of these products. So hopefully this map will change in the next few years. And where we don't have the short-term care, we have the home health care only plans. Again, all these maps are available on our site. Remember, True Freedom's available in all 50 states, that prepaid home care. So we have solutions for all your clients. And again, if you start looking at observation, that argument again, we have these rate sheets right on the site, but here's Manhattan Life's Omniflex. These are just a couple cookie cutter options for you. But look at this, for a 65-year-old on Medicare, you could get a plan in place with super easy underwriting. This is our limited underwriting plan even, so it covers just about everybody. You can see there for a single person, one married person, $55. That's before taking the $25 a month off for their prescription drug benefit. Go on our training if you don't know what I'm talking about, because I can't spend time today. But $25 off there, you're talking $1 cup of coffee a day, folks. You can get people covered with a nice $3,000 a month plan on both home care and facility for a year. 0-day elimination. Why do I do 0-day? More and more I'm looking at this saying we all sell 0-day home care. A lot of people were selling elimination periods of 20 days or 60 days or 90 days even. I tell people now, really look at the zero elimination. This is first day across the board with built-in cash for family members, and you can get it for $55 a month, minus 25 probably for most people you're looking at. That's a deal. Even when you look over here at doubling that, very, very affordable plans, especially when you take $25 off a month for the prescription reimbursement. Same thing over here. Here's our full-blown plan without inflation, but a full-blown for $12,000 a month, $3,000 a month for home care. Remember, both those can go on one claim, so you'd have up to 2 years of coverage on one claim. Okay, just wanted to remind you again, I'm going to show you due diligence here. Remember the home health care only plans, talk about inexpensive. Now plan A, plan B, and plan C as designed in the brochure with GTL, this one is. Look at a 65-year-old, $30 without taking the 25 off. These do go up in age bands, every yellow line there. Oops, I can't show you because it's a screenshot, but every age band there goes up to this next premium. But either way, very, very affordable, especially when you start looking at $600 or $900 reimbursements. And those weren't included in these premiums, so they come off over and above. We have rate sheets on there for some other products too, but I wanted to make sure I showed you that. I'm going to go over here really quick and just remind you, if I can do it, here we are. All right, my staff's going to say, Tom, you jumped around way too much, but I wanted to show you everything on one sitting since I had you on the call. And we do have the Integrity STC site, which again goes in and shows you all you need, Stratecision. This is like a $500 value that's free for Golden Care agents. So if you're not appointed, get appointed. InstaPivot, an InstaPivot underwriting tool that'll instantly show you what short-term care plans available. Then all the products we talked about are on here. We don't have Aetna on this site because this is our Integrity short-term care site. It's not a proprietary product, but we do have information. Our team has a lot of information about Aetna because it's a great product. Okay, all those are up here, the maps and everything else we showed you, and a ton of recordings about how to be successful and how to go out and we don't throw you out of the plane without a parachute, right? That's my tagline when it comes to that. Everything you need to be successful is right there for you on that site. So be on the lookout for our next WOW webinar, and I have one coming up. I may end up doing some traveling and stuff, so the first time we could sneak it in was Thursday, June 6th at 10 a.m. Central. I don't think there's much chance that date will change at this point, but again, this is going to be a good one. If you want to pencil it in your calendars, I'd love to have you join me again. This is right now, the plan is to have a complete A to Z extended care conversation starter and sales presentation. I'll have somebody I'll pull onto that, and we'll kind of do a role play and probably break the third wall a couple times and talk to agents and say, now here, if you have 2 screens, blah, blah, blah. But mainly, I'm going to try to show you that it's not that hard. We talk a lot about hitting the easy button and how easy it is to start the conversation. You're not going to go into that webinar I just gave you and say, let's talk for 15 minutes on observation days. What you're going to do is see how simple it is to hit the power statements and things that'll help develop the need and help you go in there and help those folks in the trenches. So hope you'll be on that. Make a mental note of that one, June 6th at 10 a.m. And otherwise, I'm pushing my 45 minutes here. Boy, look at that, 2 minutes below. I want to tell you this. Number one, I am passionate about this. Take advantage of some of the tools we have. Go out there because you are the last defense. You are the people right now listening in on this call who are going to be part of that solution to help those people have a conversation about this. Because in the next years, up to 2030, especially, more heads will turn. It's not going to be that dull area we had in the last 10 years where, oh, there's a lot of bad press about rate increases and people don't feel like this is a good solution. And now we're seeing people are starting to realize, wow, I'm seeing mom and dad go on claim. Maybe this is something I should plan ahead for. So long-term care, we got great solutions for you there. And if there's any health problems at all, or you just want a more convenient, powerful product, these short-term care plans are unreal. They're very strong. So apologize about this last slide. It says recovery care. I cheated and used a closing slide from a previous webinar. So apologize about that to my team. They'll know that they should probably check my work before I jump on these. But that being said, this is Tom Randall again. Thank you very, very much for jumping on and listening to yap at you for a while today. And if you have questions, I've got a great team here who'll help you out. So thank you very much for jumping on, and you guys have a great day.
Golden Care is always here to serve you with new tools, new products, new ideas, and new innovations, and always the best support in the business to help you succeed. So give us a call at 800-842-7799 and check out our website at www.goldencareagent.com.